Buongiorno. Good afternoon, everybody, and welcome to the afternoon symposium on an integrative approach for ADHD. My name is Tim Willens, and I'm joining you from the Massachusetts General Hospital in Boston, and with my esteemed panel today to give you an international perspective on contemporary issues on the treatment of ADHD, or attention deficit hyperactivity disorder. It's truly an honor to be in such an international arena and to be in such a terrific city, and we look forward to presenting 3 separate talks, and at the conclusion to have time for comments or questions, daggers, whatever, to stimulate conversation. We have question cards that will be circulated, so if you have a social phobia to get up to the microphone, feel free to complete your cards, and we'll ensure that we can address as many as possible. The fire exits at either side and to the rear of the auditorium. If you have any mobile phones, I've noticed it seems in this area everybody does, or Blackberries, please shut them down. Although you're all probably very tempted to take pictures of us, that's a joke. No photography, please. No smoking. And question cards, again, have been placed in your packet, and if you would like, you can write your question out, or we have microphones as we get to the question and answer period. We also have, to help us get some feedback and to help us all orient one another to a bit of how we think about certain issues in ADHD, we have these NITO interactive response systems. When the time comes, use the keys to vote. When Vote Now Please appears, and you'll press your vote. The red LED will be on during the voting period. There'll be a timer, and you'll hear some music. If it's possible to change it is possible to change your vote, but you have to press C followed by the new vote. So if you're changing back and forth, you're going to press C and then the new vote. The last vote at the time that the time runs out, that's your vote. The results of the vote will be projected immediately on the screen on a graph in percentages, and we know who you are, so if you vote, no, we don't do that. We'll just try to get a sense of how everybody is working together and see what we all think. So now we're going to move to our first speaker, who comes to us from Canada. This is Professor Dr. Rosemary Tannock, who has many hats, Professor of Special Education and Psychiatry. She's a Canada Research Chair in Special Education and Adaptive Technology, and is a senior scientist from the Hospital for Sick Children in Toronto, and is going to be talking to us about psychoeducational approaches to the treatment of ADHD.
So we just have good afternoon, everybody, and thank you for staying and to this talk and not going out immediately to enjoy the beauties of Florence. The presentation, as we hear, have several of these notices, standard notices, just to indicate that they're for professional audiences and subject to copyright issues. So this is standard information that we'll present in each of the presentations. If you want any further copies, please consult the manufacturers, etc. We always disclose our any conflicts of interest that we have had, our interactions with pharmaceutical companies in this case. However, in the particular talk I'm giving, this really is not an issue. I'm not mentioning anything to do with medication. There are 3 main learning objectives that I hope that you will leave with some of the following understanding. I'm hoping that after this presentation you will understand the need to include a variety of psychoeducational approaches as part of the treatment of ADHD. And perhaps most importantly, to understand the rationale for the different types of psychoeducational approaches, and to be aware of the evidence that we do have on the effectiveness of psychoeducation in the treatment and management of ADHD. But let's start with definitions. I'm sure each of you might have a slightly different definition of what is psychoeducation. So the following is what I'm going to be using here as a fairly standard understanding. It's a behavioral approach to intervention. It's provision of information and education about an illness, in this case, about ADHD. It's information about its diagnosis, its clinical course and outcomes. It's about information about common or recommended interventions, the available community supports or resources, and opportunities for questions and feedback. In this definition, though, there is no indication at all about the extent of which extensiveness of psychoeducation. It's just a standard definition of what it might include. To start with, let's talk about the questions. We're going to have a first opportunity to use the new toys, the response buttons. And this is just a fact-finding question. Do you include psychoeducation intervention for ADHD in your clinical practice? So option 1 is not at all. Option 2 is occasionally. Option 3 is often. Option 4 is most of the time. So if you'd like to press the button corresponding to your choice, vote now, please. Okay, so this is very exciting. So here we have a range, but obviously the majority, over half of the audience, is using psychoeducation most of the time, which is indeed very confirming and affirming. This might not be the same response had we conducted this poll in North America, interestingly enough. However, I think now we're saying, okay, but what type of psychoeducation do you provide? So have the next question, please. So to whom do you direct your psychoeducation? To the patients, and I've listed here because I'm not sure if you'll be treating children, adolescents or adults with ADHD, but do you direct the psychoeducation to the patients themselves, the parents or the partners in the case of adults with ADHD, the family, meaning parents and siblings of child patients, or of parents, siblings and offspring of adults patients, to teachers and other key school personnel. So please make your vote and respond now. Okay, so the majority of people are providing the psychoeducation to the parents or the partners, and obviously, presumably, the child might be included as well in that. So we've probably got this big scatter, but of interest, particularly because of what I'll be presenting, is the fact that, in fact, less than 5% of the audience would typically provide psychoeducation to teachers. So I'm going to talk about the effectiveness of psychoeducation to these different partners, the collaborative partners in the management of ADHD. But again, it's a delightful spread, and it's a good setting to start the talk. Thank you. And the next slide. And my question before I start the talk is now, what do you think, based on your knowledge of the literature and experience, where do you think is the most effective focus of psychoeducational intervention for ADHD? Is it to increase the patients' and families' knowledge and understanding of ADHD? Enhance the family's management of ADHD symptoms at home? increase patients' compliance with medical treatment recommendations, enhance the patient's academic, behavioral and social functioning in school, that is for the child patient, or it's really not effective for any of these purposes. Please make your vote. Great. First of all, I really appreciate everybody responding. We're getting a delightful input here, so thank you. Again, a fascinating spread. And indeed, as I'll show you, there is evidence, obviously, that psychoeducation is going to be effective for all of these purposes. The majority of the audience argues that they think it's obviously to increase the patient's and the family's knowledge and understanding of ADHD. Yes, indeed, but in fact, some aspects of psychoeducation can go further than that. And although only about 20% thought it might have an impact at school, I'm going to be sharing with you knowledge, some evidence that in fact it can enhance substantially the functioning at school. So again, a delightful spread of responses, so I think we have some opportunities for learning. Thank you, and back to the slide set, please. So I'm going to focus first, before I get into the evidence, of why it might be important to start thinking about including teachers in your psychoeducational interventions. There are 4 reasons. The most striking reason is the impact, the negative impact of ADHD on academic achievement. Please remember that these youngsters with ADHD are average or above average IQ. Yet the current data that has come from these national longitudinal epidemiological studies from Canada and the United States indicate that those youngsters with high ratings of ADHD, with a diagnosis of ADHD, it will predict a decline in academic achievement scores over a 4-year period, is this what this data shows, of 8 to 10%. And that is even, if I can find the, yes, here we go. So here, the data that came from these longitudinal epidemiological studies, if you had ADHD at one point in time, and we measured your academic achievement 4 years later, in the absence of any treatment interventions, your scores would drop by 8 to 10%. That's a huge amount. So this is a really serious section of information that we have on this incident. It's not just ADHD, by the way. It is even those who might be sub-threshold, so elevated symptoms of inattention and hyperactivity and impulsivity, even in the absence of a full diagnosis. But collectively, a whole series of studies now indicate ADHD increases the risk for grade repetition, low academic grades, C's and D's, that itself is a strong predictor of dropping out of high school without completing the requirements. It's a 2 to 4-fold increased risk if you have ADHD. We've talked about the low academic grades, and a recent meta-analysis of patients referred to clinics indicate that on average, clinicians could expect the scores to be about the 23rd percentile, low average range. Remembering that intellectual abilities you'd expect average or above average performance. Early high school leaving, about a year lower, etc. And even those youngsters who do get to college are still struggling in the absence of effective treatment and management. That's one reason. The second reason is that there's also cognitive impairments linked with ADHD that further impede this academic functioning at school. And that is that children, if they have ADHD and these executive function impairments, impairments in higher order thinking, things like working memory, which is the ability to hold information temporarily for about 1 to 2 seconds in your mind while you are processing information and adding new information. If these youngsters have ADHD and poor executive function, then they're even more impaired in academic outcome. They perform more poorly than those with ADHD alone. So even children with poor executive function, regardless of their ADHD, also have poor social functioning. So the implication of this statement is that if you have poor executive function and ADHD, you're also going to have poor social functioning at school as well as poor academic functioning. So we have ADHD symptoms predict poor social and school functioning. Executive function predicts poor school functioning as well. And importantly, these executive function deficits do not go away without treatment, without support. They're stable and tend to persist into young adulthood. And these longitudinal follow-up studies conducted by Joe Biederman from Massachusetts General. Notably, the one particular aspect of executive function that was evident from that study is working memory. We use this in everyday life, and that is which is stable across the span. So I'm just going to go across, I need this slide first. So what we have, in fact, is a triad of risk factors. Academic impairments associated with ADHD, but in particular, it appears that it is the inattention dimension, not the hyperactivity impulsivity dimension, that often drives the referral. It is the inattention symptoms that is the strongest predictor of poor academic outcomes. Executive function impairments do lead to academic impairments, and what we know now is that inattention predicts the poor executive function impairments. So we have what I call a triad of risk factors. So the third reason that we might want to include teachers is that, of course, teachers could make a difference. They're really well placed to identify children with ADHD. They've got the daily contact with the youngsters in contexts that are really make demands and often elicit a lot of the symptoms that bring the children to referral. In the classroom, these symptoms and the impairment thereof, particularly important, are clearly observable in classroom settings. And in fact, in many cases, the teachers are often the first to realize there's something wrong and suggest a meeting with parents. They're clearly in a position to act as central change agents. Teachers are with children many, many hours a day, and they can actually promote academic success and positive mental health outcomes in children. And as from the Australian group, having looked at all of the predictors of what's probably the most powerful effect, is that the quality of teaching in the classroom is a key determinant of children's academic, affective and behavioural outcomes. So the quality of teaching, how the teaching process is taking place, is important. However, although they're ideally situated, unfortunately, most teacher training programs do not provide teachers with the information they need. So this isn't teachers' fault. The training programs have not yet caught up to date because, of course, in virtually all countries, ADHD is not a recognized special educational needs. And so the teachers do not receive information about ADHD. So they often have limited knowledge about ADHD, virtually no knowledge about executive functioning or the effects of either of these problems on school functioning. When teachers have been interviewed, certainly across North America, they cite that lack of training is one of the major barriers. They want to help these students, but they don't understand how, because they don't understand what ADHD is. And according to the teachers in the USA, again, one of the most important topics that are requested is in-service education about ADHD. But now we need to go back to a question, a very critical question. When we think about psychoeducation, is it an effective component? A huge majority of this, most of this audience uses psychoeducation, but how do we know what it does? In 1999, the Surgeon General reported on psychoeducation. Although there are no studies evaluating the efficacy of psychoeducation as a treatment modality for ADHD, providing information to parents, children, and teachers about ADHD and treatment options is considered critical in the development of a comprehensive treatment plan. And this was taken from a statement from the American Academy of Child and Adolescent Psychiatry in 1991. So my question is, has anything changed since that time? Do we know anything more about the effectiveness of psychoeducation? So I'll first start with psychoeducation of children with ADHD and their families, since this is particularly where most people are directing their psychoeducation intervention. If we look at effects on children per se, so intervention that is targeting children, so this one is a Canadian study, and where they actually tried to demystify ADHD. So children with a diagnosis of ADHD took part in a 2-hour workshop with child-relevant materials talking about ADHD and the treatments and so on. And they also, at the end, they gave the particular workbook that was partly completed by their own child and partly additional information provided by the trainers. They gave that information to the parents. Positive outcome on child knowledge. So they were finally able to advocate for themselves. This was a very important study, although it is uncontrolled, a pre-post design, and certainly we need to replicate this. Most studies have looked at parents or family completely. The McCleary and Ridley provided 10 weekly 2-hour groups. So this might be much more extensive than you might use in your clinical practice. And again, for about 100 parents, provided a manual and video clips. Positive outcome, and this is with adolescents, a real tough group, and had a very positive outcome at behavior at home. Monastra also was a large-scale study, provided a 90-minute feedback session, but it included other measures as well. So it's a little bit more complex study, but again, a very positive outcome. And then one study I found looked at parents and children. They again provided a manual of the type of information that was presented, and they shared this information, a brochure they shared with the teacher and with the primary care physician, and again, positive outcomes. I believe there's probably one in press of a controlled study, and there may be some I've missed. But my conclusion is that there's the minimal evidence at the moment, simply because the only studies I've got here are uncontrolled, and I would be much more confident in my conclusion if I had a controlled study. But the real problem is lack of data, not lack of evidence. Is teacher psychoeducation about ADHD effective? The answer is yes. I will give you a couple of details. This Miranda study is from Spain, where they provided 8 sessions, 3 hours of sessions for teachers, and provided again a manual and video clips and so on, talking about what ADHD is, effective behavioral management, but also effective instructional approaches in the classroom. So beyond behavior, but how you might present your lessons. Improved teacher knowledge, improved parent-teacher ratings of ADHD symptoms, and improved academic performance. This Australian study was a huge study. They provided just 1 hour of in-service training to teachers, but they included in that training data from a whole epidemiological study highlighting the fact that many children in classrooms have difficulty processing spoken language. Remember, I talked about working memory lasting for 1 to 2 seconds. Just think, when I finish speaking my utterance, we don't speak in sentences, but when I finish my utterance, it'll gone. If you didn't do something and rehearse it or picture it or remind yourself, when you leave this hall, it will never be there in your head. You've got to hold on to it in 1 to 2 seconds. So what they did was to first show the teachers the data, the normal development. Second, they gave the teachers a tool, how you quickly measure, very simple measure, so they could measure all the children in their classroom and identify those youngsters who had difficulties in processing spoken language. And then the crux thing was they actually showed them how to address children differently when giving instructions, gave them very clear information plus a videotape demonstration of chunking the information. The same holds for parents or any of us giving instructions to individuals with ADHD. A brief chunk of information and pause. You need to pause long enough so the person can take that information and kind of say it to themselves, rehearse it in their head. They've only got 1 to 2 seconds, otherwise it'll be gone. So you need to chunk your information and, if necessary, repeat it. But instead of just speaking in long run-on utterances, as we often do, like go up the stairs and while you're up there, could you bring your book down, and also don't forget to clean your teeth and put on your pajamas. That utterance is impossible for the majority of children with ADHD to process. But if we chunk it, pause and then chunk again, the children will follow. So again, we saw in that study improved attention and improved reading and math scores. Merrill and Timms was a big study from the United Kingdom, where they said, well, should we actually, because of the importance of ADHD in schools, should we actually screen and should we give teachers information? So here what they did is to do a randomized controlled trial where some schools or school boards got screening information which youngsters in their classrooms had problems with ADHD, versus some schools just received booklets so the teachers were informed about ADHD and how to again manage behavior in the classroom and how to adjust their instructional practices, or they got both. And the outcome, in fact, was just providing information is the most helpful thing we can do. Just identifying doesn't actually help. It's easy to say, I can't deal with this. But if you know how to help, they could actually do very well and help these children. So when we looked at the outcomes, not surprisingly, reduced the teacher's stress, improved the children's attitude to school, perhaps because the teachers weren't so stressed and also understood them, and again, an improvement in children's reading. So sometimes this interaction between enhanced teachers' knowledge can really help. There are also several uncontrolled studies that I'll just put up here, but again, all of them are showing very positive outcomes in terms of not only enhancing the recipient's knowledge, but also, in most cases, improving their children's behavioral symptoms at school and also their academic outcomes at school. So to finish, I thought I'd just list here 3 websites that, again, you could use for your own clinical practice, and if obviously it's difficult to immediately have the materials to include teachers, but these websites I think are very useful for teachers that you could include and suggest they might want to look at. So these are documents that are specifically meant for teachers. So to summarize, psychoeducation, as you obviously are all clearly aware because you're including it in your practice, is an important component of the comprehensive management plan for ADHD. The evidence, it is effective for children, parents and family, though we really lack the data, and this I think warrants much more careful and larger scale investigation. We're lacking data at the moment, but we do have robust evidence that psychoeducation for teachers is effective. One small point is all of the studies that show effectiveness for the parents and family, etc., this is all manualized, it's formalized, not just off the cuff in a few minutes. So again, I think it's worth thinking about this in your clinical practice, that we might want to be a little bit more systematic and actually hand a document. Why? Because many parents, of course, may be suffering from the same problem. Thank you.